Welcome to Dr. Baliga's podcast for the Curious Doc. Today is June 11, 2026. This video is on a New England Journal of Medicine article published online today titled Vasopressors of Fluids in Early Septic Shock. It's an original article. Early septic shock resuscitation remains controversial. Large fluid volumes versus earlier vasopressors with fluid restriction. The methods utilized by these investigators. This study with the acronym ARISE Fluids randomized. It was a randomized multi-center open-label trial at 51 sites in Australia and New Zealand. 1,000 individuals are randomized with the intention to treat population. 963 were enrolled, 481 were on vasopressor and 482 on fluids. Adults with septic shock after 1,000 ml of fluids, a lactate greater than 2 millimoles per liter, receiving antimicrobials were included. Intervention for 6 hours and up to 24 hours. Primary outcome, days alive and out of hospital at day 90. Statistics, quantile mixed effects regression, 90% power to detect 7-day difference. What they find, 24-hour fluid volume was 1,140 versus 2,248, a difference of nearly a liter or more than a liter, 1,108 mils. Vasopressor used 86.5% versus 67.6%. Difference was nearly 18.9 percentage point. The primary outcome, median was 76 versus 76 days alive and out of the hospital. Difference was 0 days. P-value equals 1.00. 90-day mortality, 16.4% versus 14.4%. Relative risk 1.14. Pulmonary edema 0.6% versus 5%, relative risk 0.12, p-value less than 0.001. Limitations of study, open label design, intervention limited to the first 24 hours, excluded patients with major fluid restrictions, greater than 2,000 ml pre-randomization fluids were excluded, or other treatment limitations. Generalizability to resource-limited settings remain uncertain. Key takeaways, early vasopressors plus fluid restriction, reduced fluid exposure and pulmonary edema. No improvement in days alive and out of hospital or mortality at 90 days. Clinical pearls, septic shock outcomes were similar whether clinicians prioritized early vasopressors with restricted fluids or large fluid volumes with later vasopressors. The strategy successfully separated treatment exposure by greater than 1 liter of fluid during the first 24 hours. Pulmonary edema was substantially less frequent in the restricted fluid and early vasopressor approach. Early vasopressor initiation did not translate into better survival or days alive outside the hospital. These findings support individualized hemodynamic resuscitation rather than a one-size-fits-all fluid strategy. This was an important trial for emergency department management before the traditional 30 ml per kilo target is reached. This is an infographic on this NEJM article. Hit pause and read at your leisure. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.